I take this opportunity to thank Dr. Annapurna for giving me this wonderful opportunity to present our data here. In fact, we are in the early stages considering ovarian cancer. I have done a lot of work in breast cancer. Now I'm extending my studies to ovarian cancer because it's a devastating disease, and being a female, I think that is something I can do towards our community. Uh, so I don't need to introduce, I think, in the interest of time, about what is tumor microenvironment, because we have heard about it in the forenoon sessions. But basically, what we were trying to see was in breast, when we did the tumor microenvironment, we actually recently got a academic clinical trial approval from funds from ICMR to do single cell sequencing and try metronomic chemotherapy to modulate the TME, followed by low dose of immunotherapy, because you know that immunotherapy is not affordable to Indian patients. So on the same lines, we were starting with the ovarian cancer also to understand the TME. So based on these literatures available, we try to look at what the tissue resident memory cells and their contribution towards tissue resident T memory cells, and their contribution towards the recurrence rates, whether there is any correlation between the tissue resident memory cell to CD8, the effector CD8 T cells, and their correlation with the recurrence rates in patients. Of course, it's not long years of data, it is just a couple of years, but we were looking into how the patients were doing. So based on all these literature, so I'll straight go to the, I think, do I need to explain so much? In the interest of time, I'm thinking, do I need to explain about these tissue resident memory cells? They are the T cells which actually get primed, and then they decide to stay in the tissue. They start to express the integrin CD103, which will bind with the E-cadherin in the tissue environment. And if they are there, it is according to the literature, if these cells are there, the tumor should not come back. If these cells are enough, sufficient numbers are there, the tumor should not come back. So that is why we started to look at these cells, and there were, of course, many studies who found that, but not in a coordinated manner. They bits and pieces of the studies which stated that the tissue resident memory cells may be the key. So we want to look at the patients consulting at our hospital. Oh, sorry. So this is a data from 14 HGSC patients, primary cases, and 19 NACT patients who were undergoing NACT. So what we did was, of course, not Dr. Neetu and Dr. Priya Bhatti, they are the ones who provide us the tissues. And then we used flow cytometry to analyze the tissue microenvironment, because we can focus on more markers then that compared to immunohistochemistry. So obviously we need to dissociate the cells into a single cell suspension, and these were the gating strategies we applied. So interestingly, so you can see here that this is a patient. I would like to say about this patient, it was a high CD8. The top portion is cut off, but this is like CD103, CD8 positive cells to CD8. That ratio. That means if the memory cells are more, the ratio should be high. So we get around 0.4. It's not very high in numbers. It's 0.4. So we saw that this patient, the surgery was done in 2022, and no fresh complaints till now. So whereas wherever we are getting 0.2 or 0.1, there is some recurrence seen. However, there are some patients who are doing well with the low ratios also. So that is where we were perplexed, why then, that means this is not a good indicator that the recurrence will not be there. So then next step what we did was like, the immune microenvironment, if it is immunocompromised or immunosuppressive, then we shouldn't be getting into. We looked into the ratio of CD4, the CD regulatory cells to the cytotoxic CD8 T cells, and we checked whether the CRS compared it with, correlated it with the CRS score who have undergone NACT. So CRS, I think I don't need to explain this because this is familiar to all of you. So here we found that only few data we could get, still it is CRS score is awaited. So some patients we could find that when the ratio is very high, the score is bad. I mean CRS 1, it's 1 if T regulatory cells are very high. However, again here also like here you can see that the score is low, but it is only poor response. Again, this is also going against what we had hypothesized. So we then, interestingly, we looked into the tumor heterogeneity also. Of course, this is the data from not HGSC, primarily we were focusing on HGSC, but this is from endometrioid cell carcinoma because of course it was a primary case, and we, after doing all the experiments only, we could get the biopsy report that it is endometrioid. But we started with the impression that it could be HGSC. So interestingly, what we found was that this is we primarily took clockwise 4 sites, and you can see that let us just look into the regulatory cytotoxic T cells. In cytotoxic T cells, you can see that everywhere there is variation between the 4 sites. So it's real that not only the molecular heterogeneity but cellular heterogeneity is also there in the tumor, especially with respect to the immune landscape. And we found that the cytotoxic CD8 T cells, so the cytotoxic CD8 positive cytotoxic T cells was very high in site 1 and site 3. And you can notice that the same site 1 had the MDSCs very high, which are immunosuppressive cells. And then we found that, interestingly, we found that this site had very low level of effector CD8 T cells. This is the entire subsets included in this slide, in this picture. And here you can see this is only the effector CD8 subset. And if you look at the memory T cell CD8 subsets, that's again high in other sites where the MDSCs are low. MDSCs, as I mentioned to you, are immunosuppressive cells. Wherever they are low, you can see that the effector cytotoxic T cells and the effector resident cytotoxic cells are tissue resident memory cells are very high. And we also noticed that this was a very new interesting finding, wherein we found that here I told you that this CD8 subsets are very high here. The total number of CD8 cells are very high here, but when we see here effector subsets are low. You also see that this TRM also low. Then who are they? They are CD8 positive. We found that they are also CD103 positive. That means they are TRMs. However, they were CD28 negative and FOXP3 positive. So that means these cells, these suppressive cells, are secreting some cytokines, some factors which are making these cells into a regulatory phenotype. So we couldn't find many literature stating wherein they have reported regulatory conversion of these memory resident T cells. So this was just last week's data. So we want to get more samples and really characterize these cells to see whether they are really regulatory cells, or with FOXP3 expression, you know, but at the same time tissue resident memory cells. As you know, these MDSCs, they secrete many factors so that the immune environment is converted into a cold environment, and Tregs also secrete. So we think that probably the low CD8 Treg to low CD8 lead to low T resident memory cells, and low Tregs will go to the low CD8 Tregs go to and also low CD8 Trem and Treg. There will be low MDSCs. I mean, what I meant here was high. This being removed. So you can find high effector CD8 and high effector TRM CD8 cells if these cells are really low. So that's what we could understand from our studies with just 1 year data. Thank you. I can take any questions.
This is more of a comment actually.
Yeah, I'm looking forward to comments actually. More of comments.
No, I mean, I really like your work a lot. And even we've been looking at some data which is quite similar to this. And in fact, there's a lot of information in literature that says that a high frequency of MDSCs actually is an adverse leader for immunotherapy. Especially the ICI checkpoint,
yes,
which is to be expected.
Yes.
Because, I mean, this is the exact thing that is being.
Yes. Yeah, a lot of data is there, but our aim was to find out, dig more into it, like in the case of the breast cancer, where we got funds for single cell sequencing. So that's why we were making some
factors.
Yeah,
we
have to do some
really the thing that one needs. Very good. Do you see this getting worse with the subsequent cycles of healing? Have you kind of compared, like, say somebody getting after 3 cycles versus after 5 cycles or 6 cycles of chemo?
We are yet to do all those comparisons.
I mean, even between primary and NSCT received samples, do you see a change difference?
Yes.
What do you see?
So in the CT, actually we can see that the Tregs are going down and then slightly the CD8 T cells are going up. But we need to, we are not getting paired samples. That's one problem.
That's
what
you need.
Yeah.
Like, I think
in the breast we are getting paired
and
samples.
it's not only from that. I think you need to really get paired sample for a CRS1 patient versus a CRS3 patient.
You mean same patient? No.
So one patient who has really shown good response, like CRS3.
Yes, but
paired post. Yeah, paired post. And a CRS1, which is a really bad at paired post. And maybe you need to get a few of them on each.
Okay, so I actually forgot to show my collaborators. So I think
She's
Dr. Neetu and yeah, she should be. She should be able to give some paired samples. We will look into that once we start to get that. I was telling her, like, we have to look into the paired samples.
And also, like, when you get this, traditionally people do the CRS on the omental specimen. But when I started, the CRS work, I don't know, the initial paper actually, I was with Navina Singh. In the initial 2015 brainstorming when the first thing was coming out, and then we introduced it to Tata. But I know from that point that we were actually looking into the CRS, into the ovarian surface, the peritoneal surface, as well as the omental surface. So 3 sites. So I know from the clinical point of view, people have now gone into do only the CRS from the omentum. But it might be actually very interesting if you are doing a research. Depending on your biopsy, if you manage to do, I don't know, your practice that you do a laparoscopy first to decide on primary or neoadjuvant. In some of the cases, not everybody, do a family score or something. I mean, I don't do per se, but sometimes I do. And then you can, yeah, but if when you are doing the cases you are doing, then, or even when you are asking a biopsy, you can maybe ask the biopsy to be taken from one from the peritoneal side and one from the mental side. And then again, when you are operating, then try to make sure that you give a sample from one peritoneal side and an omental side. And again, when you give the sample as a surgeon for this specimen, it really matters from where you are giving as well. So you will see differential response. For example, there are some scars, there are some less scars. So I think even when you are getting the samples from the patients who are you're thinking mixed response, you can figure out. And try to give from a site which has showing complete normality. Like complete scar or near normal versus one which has got disease or some sort of disease. So you really need to have like 4 pairs of tissue, I would say, per sample. So with the pre one from omentum and peritoneum, and also post chemotherapy omentum and peritoneum, but also in the peritoneum try to get someone complete regression versus partial regression. Only then I think you will get very enriched data to actually find out what's happening. Since you take the proposal.
Yeah, so
the problem is that we usually have directed biopsies. We don't do.
No, but you can tell them if the patient would consent, because I have done this work before. I didn't look into this, but what I was doing, I was actually culturing the neoadjuvant treated tissues from different sites, just to show that those were the days when people would criticize me so much for trying to do primary psychoreductive surgery. So I would then, the CRS was just starting to come, so I would actually show, every 6 months in our, board data that, all the so-called neoadjuvant treated and responded sites, you can actually grow the cells, and they are, they have more higher stem cell population, with the subsequent cycles of chemo, sometimes are getting worse. Also the subpopulations are higher. So I think in one of them, I think it was Tanya Das and Gauri Shankar. So we had some people who are working on immunology as well. So we actually managed to see the FOXP3 type of cells going higher with the subsequent challenges of chemo. But also it depends on where you are sampling and all. So
now what I'm thinking is like, I don't know whether it's a
consent them from beforehand, while the pre-biopsy, even if you consent and then tell your radiologist or whoever is taking the sample just to take it from 2 places, and if you're doing laparoscopy, then that's easy anyway. Just to keep
I was quite intrigued by the latest finding that the CD8 cytotoxic T cell, that population contains these TRMs which are expressing FOXP3. So, I mean, that answers a lot of questions.
That was not a high-grade serous, was it?
No, endometrioid, but still that, we have to see in HDC how it is like. But, I mean, there isn't much literature about those cells. The CD8 cytotoxic TRM cells expressing FOXP3. Their conversion into the regulatory subtype.
Did you do a FOXP3 IHC as well? I'm sorry.
No, that's what we need to do. I mean, I told you just last week we got this data, and only one publication probably, which just said it can be there.
FOXP3 immunohistochemistry.
Yes.
To be very non-specific. So not very
This
informative.
is not immunohistochemistry. This was.
I know. I understood. When we did IHC,
Yeah.
we found that
So it's very non-specific.
non-specific is everywhere.
But you used only one marker, only FOXP3.
CD8 and FOXP3.
Oh, okay. So that means I shouldn't go that way.
Well, that was breast. I don't know.
Okay. Yeah.
Ma'am, have you checked CD17 population?
CD
17?
70.
17. CD17 population.
We have prepared a big 5-tube full panel, but they haven't run all of them. Titration is a big issue in flow cytometer.
That is why if you based on the discrimination based on the phosphoryl expression, you cannot distinguish. This thing is
If
lower.
we use CD70,
No, I will suggest that CD25 also.
CD25 we used.
Use.
Yeah. In CD8 we used CD28 also. Yeah, CD28 minus.
Okay. So say
25 we use.
17 you did not.
No, 17 we did. 17, no?
17.
Yeah, I'll try to use that. Okay. Thank you.